Thank you again for your invitation to be part of this important program. My title is Whole Body Health Through Personalized Diagnosis and Non-Surgical Correction of Jaw-Neck Alignment. And it is also the same as Physiologic Neuromuscular Dental Paradigm. And I come say hello from Kansas City, Missouri, which is in the middle of United States, and greetings to all, for everyone. And I'm starting off with this slide, like a tree with the leaves. It's an analogy for the symptoms. A person that is having symptoms like headaches, migraines, eye pressure, pain behind the eye, fatigue, ADD, attention deficit disorders, attention deficit hyperactivity disorder, anxiety disorder, ear pain, sleep apnea, fragmented sleep, depression, diabetes, daytime drowsiness, snoring, chronic allergies, mouth breathing, these obesity, these are all like leaves of a tree. The symptoms are what we experience. And cardiovascular disease is true as well, chronic allergies. All of those are symptoms that we see and experience. But if you go a little further behind, what is the underlying cause? Many, many times, not every time, many times it appears a jaw-neck malalignment and resulting compromised airway can be a big source of this. A root of this can be even further back. And this is coming from an experience. My practice is in Kansas City, and I've been in practice 40 years. For the last 25 years, I only treat these. And this is my area of passion. And that is why I devote all my time and energy to this. If you go a little further, possible root cause, it goes even further, all the way from birth, soft diet, a weak tongue, low tongue position, even tongue tie, the processed food as opposed to foods that really require chewing, that result in weak orofacial muscles. All of those are the root causes. And the final thing we deal with is these various symptoms. We, meaning not just dentistry, primarily medicine. Most of my patients would come with symptoms such as this: ear symptoms, eye symptoms, headaches, and so on. You wouldn't think they're necessarily dental in terms of teeth and gums, of course, but those are the symptoms they present. If you dig a little deeper, you would see they often have compromised airway, and they almost always have hyperactive musculature of the jaw and neck that are compensating for this, and also resulting in structural malalignment, if you would, structural discrepancy. So when you're looking at symptoms, we're not necessarily looking at what is perhaps a root cause that is causing those symptoms. And I won't have time to go through very much depending on the amount of time that I have. So let me invite the participants to go to this YouTube channel that I started over 10 years ago, I believe. And I have over 100 plus case history videos. And you would be surprised about the various symptoms that people have presented with, nothing to do with the teeth per se, but their symptoms were often disabling and often being diagnosed with many diagnostic labels. And yet it turned out those were diagnosed to be underlying reason was poor jaw neck alignment. I was able to also share with people what was the presenting symptoms, what were the metrics we used to diagnose, and also to evaluate the progress. So I direct you, and if you want to, you can subscribe. So we try to put one about a couple of times a month. So moving forward, let me start with one case. This is a lady that's a 39-year-old that presented a few years ago from a different state called Kentucky. They had to drive because she had severe vertigo. These were some of the things that she was dealing with. She had severe vertigo for 1 year. As noticed, some dizziness when lying in bed for 10 years, but got worse shortly after a arch braces was started. She went to many neurologists, ENTs, chiropractors. Nothing helped. She also had an eye examination to rule out any problems with the eye. Eye was normal. Neck pain and hairline. This comes from a little more digging, if you would, a detailed interview to figure out not just what they are saying, what is the story behind it? What is the history behind it? So this is what we found out. She had neck pain for almost 20 years. She also had several motor vehicle accidents. She had lower back pain for at least 20 years. And she didn't connect on any of these. Jaw pain, temple area pain for several years. These are the top symptoms. And you would notice her head is tilted one way. This is a normal way. In fact, She is unable to stand for these photos. She's actually sitting on a chair. And you can see standing up also against the posture grid, the whole body is tilted to one side. And we evaluate a lot of things, including airway and the posture and the gait. In her case, her biggest concern was vertigo. Again, you can look at the year, 2014, nearly 10 years ago, and you would see her airway even when she's standing up and erect, which likely gets worse when she's sleeping, is even less than 100 millimeters square, 95. So that is one of the many things we looked at. We also look at the posture in terms of head position in relation to the shoulder. Ideally, the shoulder should be the ear hole, external auditory meatus, should be aligned with the shoulder, except something is making her SCM, these are the muscles that bring the whole head forward. There must be some advantage. Oftentimes the advantage is improved airway. Immediate concern is to airway. Improved airway by bringing the whole neck forward and posteriorly rotating the skull so that there's more airway here, even though there's a consequence to it. Could be the malalignment of the upper cervical is a common one. Here, this one shows ideally the alignment of the ear hole, shoulder, hip, and knee should be on that line. She's not. So she went to Vanderbilt University, which is a well-known hospital in Tennessee. She was there for 9 days as inpatient. A whole diagnostic team of neurologists were going to try to figure out what her problems were. These were the things from her medical records. Bronchitis, vertigo is the biggest one, migraine. They also had a mixed anxiety disorder and so on. These are some of the medications she was on. You can to do with the being able to breathe better. And then gabapentin, those were the symptom medication she was on. She had the whole slew of medical diagnostic tests done. She had a CT, CTA, with and without contrast. She also had impression, MRI. Impression came out as normal. So at the conclusion of 9 days of extensive testing that included even spinal tap to check the cerebral spinal fluid for any problems and there any infections and so on, they all came out normal. So they concluded at the end of 9 days, no known cause. They advised her to get psychological counseling to accept her symptoms. She had disabling vertigo. She could not even take a shower. Somebody had to come into her house 3 days a week to help her take a bath. 39 years old. She's supposed to accept it as her life, the rest of her life. So they decided to come to Kansas City to see if I can help. Again, I want to point out to you how the head tilts one way, her glasses tilt one way. This is how she is. And her eyes were checked out to be normal. This is she's telling me the her symptoms and so on, but in the interest of time, I'm going to fast forward to let me see. It's not playing. Okay. I wanted to show the video. It looks like it's not going to cooperate with me. For being unable to walk, and then she'll be able to walk and run. Cannot play media. All right. For some reason, it doesn't allow me to. But basically, the reason for showing that is she was able to not even walk, and yet after correcting the jaw alignment, she was actually able to run, and I'm unable to show that one. But why do we even worry about that? Cervical posture and mandibular posture are functionally connected. We can't separate those. There are numerous references that show this and also seen in clinical experience. And this is one of the many references, and Cranio back in 94. And this is another one. It's concluded that TMD should no longer be viewed as a local disorder of the stomatognathing system, the upper quarter. including the stomatognathic system, cervical spine, and shoulder girdle should be evaluated in patients with more complex or persistent symptoms in the head and neck region. That pretty much describes almost all of my patients. This is the reference back in 96, including Delu and so on. This is on Journal of Oral Rehabilitation. The next one is, these findings support the notion of a functional linkage between the human temporomandibular and craniocervical regions. They suggest that functional jaw movements comprise concomitant mandibular and head and neck movements which involve the temporomandibular, the atlanto-occipital, and the cervical spine joints that are caused by jointly activated jaw and neck muscles. That pretty much describe how things are functioning. So how can we ignore the rest of it and only look at the teeth? How can we ignore and only look at the jaw joint? It is really a bigger thing. It is a human organism is much more complicated than the way we're used to looking at eyes alone, ears alone, teeth alone. We need to look at the whole body view, if you would. This is Zafar et al. Back from 2000. So presenting symptoms related to compromised neck area, these are the common ones people complain about. Pain behind the eyes, forehead pain, vertigo, pain on top of the head, scalp pain. They even say painful hair. So these are some of the common ones, chronic migraines. If you hear any of these symptoms, then you should be thinking about more than just jaw problem, more than that. It's a neck as well and beyond. And this is one of the reasons why the second order neurons that go from both the facial jaw area as well as the neck, the C1 efferents, the three branches of the trigeminal ophthalmic division, maxillary division, and mandibular division, V1, V2, and V3, they converge on the second order neuron from C3, C2, and C1. This is one of the reasons why problems with the neck can often be felt or referred to the facial area, the jaw area. So it is not a question of whether or not we change the cervical alignment when we change the bite with an orthotic, anything at all for that matter. We do that every time. We do that every time. We just don't have the option about that. The only question is, are we going to change the cervical alignment for the better, or just hope it works out better? You know, we just do them and hope it works out okay. You know, hope is not really a strategy. Ignorance of this fact is not a good excuse either, for that matter. So we had to ask, are we treating temporomandibular dysfunction disorder, TMD, or really treating cranial, cervical, mandibular dysfunction, head, neck, jaw dysfunction? To me, this makes more sense. It's a little more descriptive of the problem we are facing, not just the jaw. So CCMD is something that I propose we use. I have proposed for some time. So what we often find from surgical literature is most of the problems are on the C4, C5, C5, C6. Most surgeries are done, herniations and so on happen a little further down, lower vertical, cervical. But in fact, the dysfunction originates in the upper part, craniocervical part. The first one is often called a yes joint, like this. Second one is called no joint, side to side. C3 is like a maybe. So this is a term Dr. Wakabato came up with to explain that. But C0, C1, C1, C2, C3, C2, C3, these are the common areas of problems. Why is that the case? One of the big reasons for it is this. Vertebral arteries go through this vertebral foramen. They go on to perfuse the brainstem. They go through a tortuous route through the vertebral foramen and make a 90-degree turn in humans by C1 atlas before it goes into the skull. And it is an inherently very vulnerable area. It allows us to speak, in fact, because that's what allowed us to speak, to develop the voice box. It also allows us to be able to turn around and look. All those things are there, but it's also the case there's a stability is rigidity, mobility is vulnerability. We're much more mobile there, but that allows us to be much more vulnerable. So the muscles have to do the work to keep us stable there. So are we really connected? Connected through the whole body? I submit we do. We often look at the muscles as origin and insertion. That's what all of us were taught. But in fact, there's a whole fascial web that connects the whole body. And this is one book, Anatomy Train, that talks about how all of these muscles are connected into long chains. This particular one, superficial back line, starting from the plantar fascia And what we call ligaments and tendons are all really fascial sheets and go on to the calf muscles, hamstrings, erector spinae, all the way up to nuchal line, even the top of the up to the forehead, all one line. That is not just in one area. This is again from Anatomy Train. The whole body's like this. This then allows us to know why an area that is far removed from one may have a big impact on the other. In fact, it also explains acupuncture, yoga, and many, many other things. So because we're all connected, the whole body's connected like this. This was proven time and time again by fresh cadaver dissections. And let's look at the body posture and TMD. How's it all connected? Posture is defined as the alignment of the body segments at a particular time. Posture is an important health indicator, and postural abnormalities are associated with a large number of disorders, including pain syndromes, generalized or regional musculoskeletal disorders, and respiratory dysfunction. This comes from the work of Dr. Ventura. This is all these various references. Again, I want to credit Dr. Ventura for providing these. And let's go to how this is evaluated. If you can look at the left side, that shows the optimal alignment, your whole shoulder, hip, knee, slightly in front of the ankle. This is showing all these compensations. This is a patient of mine, and we identified these using this program called Posture Pro to evaluate this. Ideally, the whole body should be lined up on the green line, not on the red line, which you would see would necessitate all of these strings of muscles and fascia all the way from the bottom of the foot, plantar fascia, all the way up to the forehead as one line. And the whole body has to work all day in terms of being in a active mode, a fight or flight sympathetic mode, just to keep the balance. So in a normal neutral posture, the plumb line should be, just as I described, should be all the way through here. The whole body's more leaned forward. He's not doing it on purpose. That's how she feels. Feels normal because the brain feels more stable there. It's a postural strategy, if you would. Again, this program allows us to actually use measurable metrics so we can check them. That is an aside. So for every inch the head moves forward of the shoulders, an additional 15 to 30 pounds of tension pull engages the posterior cervical muscles. Tension force in pounds of pull. For every inch the head moves forward of the shoulders, the weight of the head effectively doubles compressive force in newtons. Most attempts to correct the posture are directed towards the spine, shoulders, and pelvis. All are important, but head position takes precedence over all others. The body follows the head. Therefore, the entire body is best aligned by first restoring proper functional alignment to the head. This was said by an MD, I think he's passed away since, Rene Callier, former director of Department of Physical Medicine and Rehab at University of Southern California. So he's not a dentist, but he's recognizing the head position is the key. And I'm submitting to you how the jaw and upper jaw, which is part of the head, aligns, which also affects the neck, is the primary thing to be looked at as the primary cause of many of these. This is a different reference. For every inch of forward head posture, it can increase the weight of the head on the spine, but an additional 10 pounds. And the numbers may vary, but the idea is simple. It adds an additional stress. So someone with 2 inches of forward head thrust is adding 20 extra pounds of pressure to the axial spine. This added strain forces the muscles in the shoulder, neck, upper back to work overtime to right the added burden, leading to a plethora of potential pitfalls, including tension headaches, increased pressure, blood pressure, disc herniation, arthritis, pinched nerves, eye and ear dysfunction, TMJ, fibromyalgia, loss of lung capacity, all of those things. That is from the American Journal of Pain Management. But what is the key? Fixing the jaw neck alignment. It looks as though this is one of the issues, but that is a primary issue. So what did I do in her case? And again, I was unable to show the video, and I'll show other examples, to optimize the cervical muscles at the dental chair. Again, I'm a dentist, so I have over the years developed a protocol called Raman protocol, CCMD protocol. These are the components. We use ultra low frequency TENS of a spinal accessory nerve, and this is the term someone else brought up, Prabu point. It is basically ultra low frequency stimulation of the spinal accessory number 11, cranial nerve that allows us to essentially contract, let go, all of the muscles controlled by that particular motor nerve. Moist heat for neck and upper back with hydrocolloidal pads. When muscles are being pulsed like this, it also has an antidromic effect, which blocks the normal movement of the muscle, so I'm providing heat. Knee and neck support, and I'll show pictures of it. Sensory deprivation, sleep mask. There are studies that show when the eyes are closed, your brain goes into the alpha mode, basically a light sleep mode. So it is very useful to have that one. In fact, most of the time, my patients fall asleep. Craniocervical physical therapy. I will credit to whom I learned that from, Dr. Mariana Rakabada from Chile. And then on top of that, yoga breathing, the pranayama, deep breathing. The word synergy is often overused. It is basically the idea if you combine several things, 1 + 1 is 3 instead of 2. Additionally, what I have found by having all these 6 components of my protocol, it's been extremely successful, and I'll show you some examples. So this idea of having the Prabu point, again, someone else named it, was initially published in 2006 and submitted in 2007 in Vicenza, Italy, the International College of Craniomandibular Orthopedics Anthology. This is the book, The Application of the Principles of Neuromuscular Dentistry in Clinical Practice, Volume 9. And this is my paper that was submitted back in 2006, published in 2007. It's a long title, Neurally Mediated. That's important. We're not just doing pain control. We're going through the nerve, controlling the muscles that are on that motor nerve, contract and relax, to cervical and upper thoracic musculature as an aid to obtaining improved cervical posture and mandibular posture. To stimulate the cranial nerve, number 11, the myotrode is placed. Myotrode is the pulsing mode, that pulsing pad, if you would, that is placed at the inferior and posterior, at a point inferior and posterior to the mastoid process in the upper portion of the middle 1/3 of the posterior cervical triangle. I know it seems like a mouthful. When I did research for it, I did research on the thoracic surgery literature to see how surgeons locate this particular nerve. Believe it or not, there's a procedure. They actually go back and cut the nerve. So that is where they described how that is found. That is where that best position to access from the surface is. Again, someone else called it Prabu point, the name stuck. So it is in the posterior cervical triangle, which is defined by, on the back, it's anteriorly the SCM, sternocleidomastoids, in the back, posteriorly by trapezius, on the bottom by the clavicle. That is a posterior cervical triangle. If you use this technique, it doesn't matter someone has a long neck or short neck, that still works every time. If you do top 1/3, middle third, lower third, where those two meet would be the ideal place to find this nerve. So to locate it, have the patient turn the head against, give them some resistance to turn against. They'll make the SCM taut. I'm demonstrating here. Obviously, this patient is not, this is one of my assistants. She's not fat, but somebody's really obese. This technique is really useful. Don't make them turn the head. The head is still straight, but they're turning against load, against the resistant, that make the muscle stand up so they can find, you can locate that the point. So this is another way to show where that is. So this is an action. I'm hoping this will show. The media is not playing. Media is not playing. What it would show would be that these muscles would be pulsing. That's what I wanted to show. And I'm afraid I have more videos. Looks like I'm not going to show them either. I had to just describe them to you. I have 2 leads, one for the face. This is for the mandibular notch that controls trigeminal nerve and facial nerve, number 7, 5, and 7. That's a classic neuromuscular. This is my addition at the neck. That is for the Prabu point that controls the SCM, traps, in fact, all the cervical muscles. This again, I'm afraid the video is not going to work, but I'll try. No, video is not going to work. What I wanted to show is how the neck is, how I first check the neck to see what the rotation is. In his case, there's no rotation. And then this is not him, but I want to show what I actually do. 2 machines. I have heat on the neck, heat on the back, and then knee is propped open, propped up, I should say. Take the pressure of the lumbar area. Eyes are closed. There's actually cotton rolls between the teeth. They're pulsing. Again, pulsing. And you can see the neck is propped up. Two machines. This one you will see two leads. And sometimes the traps are too tight. I need to use two leads, two machines, J5 from Myotronics. So pre-PT, before we do anything else, 0 degrees side, no rotation at all. After relaxing, and again, the video, unfortunately, is not going to show, there's some improvement, 45, 60, this improved. Then after long axis distraction, again, I wanted to show you all the videos, how this is actually accomplished. That is the long axis distraction will be basically going straight up the spine, long axis, distract. And then this is an assisted C1D rotation. Again, I wanted to show the video. It looks like that's not going to be happening here, but that you can see what he's doing is I have this head in this position, side bend and rotate and hold the head. What he's doing is putting pressure against this while he is doing the deep breathing pranayama. So what that allows it to, I'm not pushing, I'm offering resistance. By him doing it, all of these muscles will release, head will come down, then go the opposite way. And then post PT, his neck was, again, I'm unable to show the video, but he had a full rotation. So that is the process of doing this particular technique. Let me show an example of a case. This might be informative. This is a young lady that was referred to me by a local dentist, and her problem was left side jaw pain, limited mouth opening. She can't even eat a sandwich or yawn too wide, throbbing throughout the day, live with the pain of 5 out of 10. Opening and chewing will go to 7 out of 10. But she has to stop chewing at the time because she knows it'll get worse. That was the primary reason for coming to me. But I always ask people, what symptom affects your quality of life? I know we are used to going to an eye doctor for an eye problem, ear doctor for ear problem. Those are different parts, different physicians, different specialists, ophthalmologist, otolaryngologist. But when you come to a jaw doctor, TMJ doctor, they often relate only their jaw problem to me because I'm going to a jaw doctor. But I ask them, think of it like a wish list, like a genius wish list. What symptom really affects you the most? Just forget that you're coming to a jaw doctor. Oftentimes they'll reveal other things. She had migraines for 15 years. At age 16, she's only 31. Neurologist did not help. Currently 4 days out of the week, wake up with some headache, migraine 7 to 10, 5 times a month. She just lived with them. She would have never mentioned this to me were I not to have asked her, what affects you? Poor sleep. It takes her 40 minutes to fall asleep, wake up at least 6 times a night, and I'll show her picture in a second. She's hardly an obese person, and since high school, she's 31. Talk and sleep per partner. She would even speak. These are all telltale sign of sleep breathing disorders. If you look at her, no one will suspect she has any kind of sleep breathing disorder because she is very young and not at all fat, skinny, healthy. You wouldn't expect her to. But when I ask further, she wakes up with very little energy on a scale of 0 to 10 and peaks about 9 out at 11 a.m., ran out of gas, meaning no energy left by 2 p.m. None of these would have been brought up. She also had acid reflux for 8 to 10 years since college. Smaller meals help. She's been managing. Remember those images that I showed in the very beginning? These are like leaves on a tree. There's one leaf here, migraine. One leaf here, poor sleep. One leaf here called acid reflux, a GERD, gastric reflux disease. Those are all various symptoms, but there's often an underlying commonality, which I submit is a poor jaw neck alignment. You would see on this, these are her symptoms. Anything you see bright yellow is what she filled out. You talked about a jaw pain. You talked about limited mouth opening. When I got to asking her further, she actually has a back pain and she actually has a neck pain. In fact, she was told by her father in his 50s, he had back surgery. This is just our build. We are very lanky, skinny people. We just have this. This is just, we are tall and lanky. That is why. So she had accepted she will have surgery someday. These are the other symptoms she had in slightly different yellow that she did not mark. But when I talked to her, she said, oh yeah, that applies to me. So we marked all the other things, sleep disturbance too, she never mentioned before. This is one of the things that we do among many things. It is a palpation, usually about to 3 pounds of pressure in various places. I have 44 places that I normally, that's my protocol. Each of them there for a reason. I don't have the time to go in, but let me point a few things. This is a posterior joint space through the ear hole. The back of the TM joint is the front of the ear hole, right? This is also lateral TMJ capsule, stylomandibular ligament, SCM. These are the various things that I check. Occipital right at the hairline, and craps. Is this inside the mouth? Again, they all have reasons for why I picked them, but they tell me how they are. But I use the same technique, same amount of pressure, same clinician, same patient, same response. I do acknowledge the response is colored by many things. The pain is something a person feels. You know, it's a symptom. It's a subjective response to an insult. Have 3 pounds of pressure. It is colored by many, many things. Young people have a lot less pain than older people. Athletes feel a lot less pain than non-athletes, and men feel a lot less pain than women do. And of course, medications people are on these days, they all have an impact on the pain perception, but it doesn't matter. It is just what that person feels. So that is your control, if you would. Nothing has changed, same person, same examiner, and we check them at various times. This is when she started off with. The score is 97 over 132. 33 out of 44 would be either 3 or 2. That's one way to measure all the painful points. Or if you just add all the numbers, possible 132, she is 97. And you can see a few things. She has some bone loss. You can see recessions. I call them bone loss because it's from clenching. You have abfraction, you lose the bone, and then the gums follow. And you can also see the scalloping of the tongue. Those are all indicative of sleep breathing problems. And her teeth look good. Her bite looks good. She had braces before. 4 out of 5 people that I had treated had braces before. Among many things, we also take CT scans, cone beam CT scans. I've been doing some 2006. You would see her right joint on a on the coronal view is really deformed, degenerated compared to the left. A little close up, I measure the distance too. Ideally, it should be like this. More like the left side. Even left side shows some thinning of the bone. Again, only 31 years old. Right side, left side sagittal views. And you can see even on the fossa, some areas really very thin right there. That's her. Her name is Chaya. And again, we look at the are things level or not. And you can see the eyes are not level, hips are not level, the whole body is leaned to one side. Somewhat similar to the other lady that I showed. Unfortunately, I was not able to show you the video. Again, this is side view. Ear hole should line up with the shoulder. And that should be where that should be. The whole head is forward. Again, the SCMs, sternocleidomastoids, are the ones that bring the head forward. Why? So that there's more airway, and the pharyngeal airway is open. Just like when we do basic life support, bring the head forward, bring the jaw forward, tilt the head to open the airway. Same thing is happening, except it is done by the brain to keep her alive, if you would, when she's awake. It also puts a lot of tension right at the nuchal line, which is the source of a lot of these headache problems. So that is her from the side view. And if I put from here all the way through, and ideally the whole thing should be lined up here, there's a lot more tension on the neck is coming forward. So there's a compensatory excessive lordosis of the lumbar spine where her back pain is. And so there's a postural compensation. And I do a balance test. I don't have a video of who not have probably shown anyway. I check her balance by checking how well they can resist me pushing down, then compare to on a wall to remove everything below the shoulder as the variable would be giving support below the shoulder, and then put the myobite, which is a diagnosed position. I'll show how we do them in a minute. In her case, it's a tremendous improvement. What does it tell us? All day long, all of her body would be in a constant sympathetic mode because it is a fight or flight. She cannot lose her balance. All these muscles are never being able to take a break, means it's always working. So presenting versus diagnosed law position. This is how we go through. These are the electromyography, surface electromyography leads or temporalis, masseter. This tells me about the jaw position, SEM, and then we call them digastric because it really tells me about the airway problem, tongue problem. This tells about the head position. On the left-hand side shows post-CCMD protocol. Again, the CCMD protocol is where I have done the heat, pulse, and the physical therapy, all of that part. That's my protocol that I described earlier. This is after that. Left side shows teeth are not touching. Right side teeth barely touching. How do I know they're barely touching? The masseters are not much more than 5 microvolts. So they're barely touching. So the difference is just to put the teeth together, those muscles had to work that much harder. You can see the right side muscle has to go 2,300% more than when they're not touching. Left side is almost 700%. Do you remember the right joint was the most damaged joint? Additional pressure led to more destruction of the condyle on her right side. And this is how we figure out where the jaw should be. You would notice her feet are down on the floor, and then there's a pillow in the back to have a good posture of her lower back. Again, the neck posture and the lumbar posture work together. So I have her sitting using a cord to sit up nice and straight, optimal posture. And you would notice maybe even a little device that I added on to make sure the head is level. This one showed her current jaw position, at least in the front, compared to where she is now. It ideally should be 4.1 millimeters inferior, 0.3 millimeters posterior, 1 millimeter to the left. It is very precise. We go to the next level, where can I identify all these muscles in real time? This is the one here on the sagittal view, one here on a frontal view, where she currently touches her current occlusion, where she pulses is more to the left. So there's no way to find all of this. And this each individual square here only represents 1 millimeter. Each of these dots is 0.2 millimeters. So very, very precise. Here exactly on it. When I went about 1 millimeter more forward, more anterior, her muscles are even calmer. So I'm going to pick that as a position. And that is where we took the bite. Then compare that to with the teeth together. This side shows teeth not touching. This one shows where the teeth are on the jaw is on the myobite. So it allows me to know ahead of time, before we ever start, what is the potential improvement in these various muscular activity. 94% reduction in the activity of the right temporalis, the right side joint problem, and 83% on the left side. So she can put the teeth together more effortlessly there. Where's that? This is digital model photos. Current occlusion. This one shows the proposed occlusion, or diagnosed occlusion, I should say. Diagnosed occlusion. Now that distance has been taken up by a fixed orthotic. I don't have the time to go into why I prefer fixed orthotic. This is my preference for many reasons. So this is how she functions 24/7 for no more than 90 days. That's it, 90 days. In fact, and this is from the lingual view, how the current teeth are in occlusion, presenting occlusion, the diagnosed position. That distance makes a big difference. Again, from the side view, same thing. Diagnosed position, you would notice how one side is more than the other. There's a torque. That is, again, the problem side with the right joint. That side decompresses more. I'm not making it do that. I'm just allowing the muscles to be relaxed and go where it goes. And that distance is made up by the fixed orthotic. This is an occlusive view of the fixed orthotic. That's her immediately post-delivery, instantly. Her neck instantly got somewhat better as soon as she stood up. 5 weeks. She didn't wait 90 days. She could tell the improvement almost immediately. 5 weeks of phase 1 fixed orthotic therapy. This is one way that I measure them. This is in their own words. This is not a pain scale. It's an opposite of a pain scale. 10 would be ideal, 0 would be worse. Every single individual symptom got better, some more than others, in her own words and her signature. In her opinion, 80% better. That's her subjective ones. Headaches went down 80%. Migraine went up 98% better. Neck pain went 95% better. Sleep was 75% improved. Acid reflux is resolved in 5 weeks after all these years. One of the many things we did, we repeated the pulse palpation. This is before, this is after. Quite a difference. This is one of the many metrics we use. This is a gift that shows instantly, as soon as I put the jaw in a better place, jaw and neck, the head position, the neck posture is starting to improve. Same thing about the joint. You can see on the right one, the problem side decompress a lot more than the other side. They both decompress. Am I doing it to a specific distance? No. I'm measuring the muscles. That is a physiology. and then put them where they should be, and making up the structural discrepancy. That is the phase one. So what do we do long term? I can't leave them attached to the teeth the rest of our life. It's like a cast for a broken leg or broken arm. It's not meant to be forever. We want to be sure we are changing, we are making improvements in their symptoms. I never would do something that is irreversible. Way too often, many things are done irreversible, be it surgery or even being adjusting teeth. Equilibrating natural teeth without knowing for sure that'll help, to me, is irreversible change, in my opinion, because you can't put it back where it used to be. But phase one is always reversible. Why do I do that? Even though after 25 plus years of treating these patients every single day, I'm not able to fix every single person by 93%, which is not a bad rate, but there are about 7% of the people, no matter what I do, they tell me, again, subjectively, I don't feel better. I had to take their word for it. I'm not going to question them. I can have all the data to show things improved. It does not matter. Those things are just there to guide me because I'm not able to feel what the patient feels. So I had to ask them, how are you feeling? And again, like the form, you get a blank form, they just fill out what their symptoms are, what level that day, then we can track, are they getting better? Once we have done that, we need to give them some options. These are some long-term options. I can move the teeth. I can move the teeth to where they should be. And I'm going to show you some older cases. I don't want something that I just finished yesterday. I want you to see the stability of the results over time. Neuromuscular, functional orthopedics and orthodontics. Neuromuscular, because we are measuring the muscles, and that is the whole paradigm, physiologic neuromuscular. Orthopedic, because we are moving the teeth. Orthodontics, we are moving, orthopedic, moving bone. Orthodontic, we are moving teeth. With fixed orthotic to start with. This young woman had a 6-year history of migraine, neck pain, TMJ pain. She was a college student at the time. I want to say maybe 20, perhaps, something like that, 2019 years old. So these were with the fixed orthotic. These are the advantages. I can maintain and further improve the symptom relief from phase one. I don't remove the orthotic. If I do that, I'll go back to square one. We don't want to go that. The only time you remove it is if they say they don't feel better at all. It improves the arch form, improve the jaw neck posture, improve tongue space for the airway. Again, if you get the more room for the jaw and the upper jaw, allows more room for the lower jaw, gives more room for the tongue. That allows the airway to be improved, neck to get better. We are resolving a lot of these things. Again, think of the symptoms as leaves on a tree. The more we get to the root causes, we get rid of more of those, rather than just taking away some of those leaves. That's what medications do. They temporarily take the symptom away. They grow right back, right? What we want to do is get to the root cause if we can and fix it. We can also correct the anterior angulations. Moving the natural teeth into neuromuscularly balanced position conserves the tooth structure. Optimal for healthy and restored dentition. I'll show you in a minute. It's a young woman with healthy teeth. More time consuming though. It's not a quick one. Takes about sometime over 3 years. Requires excellent patient compliance. Tooth color, tooth wear is not corrected. We have the same teeth in a better position, and existing endo teeth crowns, there are some complications. May result in anterior spaces. We let them know ahead of time. If the teeth are here like this, once I correct the arch shape, you're going to have spaces. Not a surprise later. This is all informed decision. They have to know all the consequences before they ever start, so they are making informed decision. But I do tell them, we can always make if the appearance is a concern, I have the tools I can do. I'm also a aesthetic dentist. I can change my hat and make them smile makeover. So that is an option for them. So this is how she presented. You can see the pain in her eyes, I think 18 or 19 years old. And that is her post-ortho, again, conventional ortho. Teeth look nice. And this is before digital, so as you can see the stone models. This is a diagnosed position. What I showed a little while ago was the digital models, but you get the idea. We can, same concept, just done differently. That is her fixed orthotic, made up the difference in this diagnosed gap, if you would. This is a gap analysis between the structural discrepancy to which the muscles had to work, which results in jaw problem, neck problem, airway problem, everything else. So this is her fixed orthotic. And now I left the fixed orthotic alone. I'm starting to work on her upper arch. Again, how we do it doesn't matter. In this particular case, I use this arch, Wilson arch, to widen the arch and then go through. Now I have the upper arch in the 018 by 025 stainless steel. Now that tooth is way down here. I remove the fixed orthotic over that one tooth only so that I can bring that up. And I'm using this technique to bring the tooth, gum, periodontal support, bone, everything together. I'm doing in stages, and eventually I'm bringing all her teeth up so that their own natural teeth come together where they should without any orthotic in. It looks very similar to the first one, but the distance has changed. That's her arch after. Join before, join after, join before, join after, join before, join after. And we also use the muscles. We also use the EMGs to check. This is before, rest to CO, meaning the amount of effort it took. This is after. And we do jaw tracking also, before and after, before and after. So a lot of metrics are used to guide my treatment, but ultimately, patient decides how they're feeling, how much they're improving. This treatment was completed January of 2012. She continued to be pain and symptom free. Another way, one more option that I can give patients is I can make this improvement, but remember, I have to, on a neuromuscular functional orthodontics, worn teeth are worn teeth. I can't unworn them. So this is a medical student at the time. She had a 10-year history of headaches, TMJ pain, neck pain, worn teeth. This kind of a pain did not keep her from being in medical school. She actually had a dual, while she was medical school, she was also going to business degree, very motivated young lady. The advantages to this particular option, full mouth reconstruction, it always, almost always in my office includes ortho because I haven't seen too many cases that arches are ideal just in the wrong place. Arches are often narrow, crowded, and all those things. I need to correct that in preparation for a better end result of full mouth reconstruction. What are the advantages? Shorter treatment time, about 12 months instead of 3.5 years, potentially 2 to 3 years. Optimal smile aesthetics, because aesthetics are part of the treatment. More conservative preparations. If the teeth are here versus here where they should be, I don't need to do as much preparations of the teeth. If the teeth are crowded versus already open, I don't need to prepare the teeth that much. Occlusal forces are along the long axes. We can move the roots where they should be, so the occlusal forces are along the long roots, along the teeth, along the tooth roots, along long axis of teeth. Able to handle suboptimal crown root ratios. Ideally, we talk in terms of crown root ratio be maybe 1 to 2 or 1 to 3, the clinical crown versus a root. When you're controlling the muscle forces, we are able to exceed those and have even taller teeth in the back especially, and be able to do that okay. We had to develop that maxillary arch form first, develop the mandibular arch form when needed. If the front teeth are like this, crowded, we can correct that. Unravel the mandibular anteriors, correct the incisor angulations. We get a lot of advantages. These tools end up with a better end result. Her name is Stephanie. She was in medical school at the time, probably about 22, something like that. That's her areas of pain. Worn teeth, pretty worn teeth. She had, I think, some composite buildup on these teeth, pretty overclosed. That change may look shocking to some. It doesn't matter. I'm not really going by what I look like. I'm going by the measurements of the muscles. So this is her, again, the phase one. Phase one is reversible. If she didn't feel any better at all, I could have taken it off. Now I'm working on the arches, and I'm also expanding the arch. Again, different techniques are there. In this case, I'm using a loop to get a better arch width on the top. Now, this is upper arch is optimal. But the lower teeth are way down here. If I were to add porcelain to all of the teeth, they look very long, especially front teeth. We don't want that. So I remove them so that added braces to the front part of it. I can attach them to the fixed orthotic. Now I'm going to bring the teeth up to a little better position and also unravel them so that I can have a better looking teeth, better appearance of the gums too. Now they're up higher compared to here. See that? And I'm also using a laser to get her gingival architecture nicer looking. Now I'm wearing a aesthetic dentist hat, doing the smile makeover part. Her symptoms are all, again, she started here. We start off with the blank form. If we give it to them, go back and say, where did they start with? Did the symptoms get better? If so, how much? Did any of them get worse? None of them got worse. Some of them got a little bit better. Some of them got a lot better. In her own mind, 90% improvement. So that's the finished case. All porcelain on all the teeth. The preparation is done in one visit, typically about 4 or 5 hours. All of the teeth are done. I've maintained that alignment optimally, alignment very precisely, and then all of them are delivered at one time. My measurements better be exactly on the money because all 28 teeth have to fit right. That is what we do. We do it quite often. This last month, I did 2 of them. So we do them routinely. It's just one option. I never tell them what they should do, but I want them to be able to have options and the well-informed decision after they know the consequences of each of those. She happens to be a physician, pain management physician now. So she even wrote a letter opposing the idea of orofacial pain being given the specialty, but they didn't care. So this is a completed treatment. The treatment was completed back in, let me see, 2010. She's continued to be pain-free and symptom-free. So this is a result we can say, what, this is 13 years later, 12 years later, long-term stability can be achieved by the physiologic neuromuscular paradigm. And I'm open to contacting with you. I have my website there, Twitter, the YouTube channel that I also already mentioned, Facebook. So thank you again for your invitation. And thank you for allowing me to share my passion with you.